So this is part 2 of our chest and vascular lecture series. And I wanted to start off by talking about TB because it's a high-yield topic. It's just sort of reviewing the vocabulary words and then touching on some of the trivia that I think is testable. So TB can be basically thought of as 3 different categories or flavors: primary, primary progressive, or post-primary, which some people will call reactivation. So primary TB can be thought of sort of like this. You breathe in the bug, get infected, you have a normal immune system which reacts and walls this thing off, it becomes calcified, and when you see it on chest x-ray, people will refer to that as a gone focus. So that's your calcified granuloma. That's the sequela of a primary infection. Now, if that infection manages to track back into the hilar lymph nodes, you end up with a few lymph nodes that are infected also, and then you have a normal immune response. Those get calcified. That whole situation, the calcified granuloma and the hilar lymph nodes, is referred to as a Ranke complex. If you have a situation where one or several of these lymph nodes grows out of control and bursts, and you end up with hematogenous spread of this infection, that's how your miliary TB occurs. And that's only seen in a small group of population. That tends to be people who are not immunocompetent or normally immune. Pleural effusions can occur as well. They are much more common in adults. They are rare in kids. Some trivia regarding this pleural effusion: they tend to occur about 3 to 6 months after the infection and are more of a hypersensitivity reaction than actually spread of infection. As a result, if you would tap that fluid, it's only going to, about 80% of the time, it's going to be negative. You're not going to have any growth. Risk factors for progression to active disease after exposure, where you're unable to sort of wall that thing off, that's going to be someone who doesn't have a normal immune system. So the poster boy for that is HIV, and that's going to be the, quote, strongest risk factor. And if somebody would ask you that kind of a question or word it however, that's what you would go to first. Now, there's a whole bunch of other stuff that can do it too, things you might not think about. People who've had weight loss surgeries, people who are just sick people, drug or alcohol abuse, or people who have had silicosis. Silicosis is a risk factor for TB. So that was primary. Now let's talk about primary progressive. So the general idea here is that you get infected, but instead of walling off like a normal immune system would, you get local progression of disease and the development of a cavity. So cavity isn't always reactivation. It can be this primary progressive. Now, post-primary or reactivation TB is probably the one you're most familiar with. This is the person who at some point has gotten infected, some period of time has gone by, and then there is an awakening in the force, and they reactivate. Now, it tends to affect apical and posterior segments of the upper lobes and the superior segments of the lower lobes. These are the areas that have higher oxygen tension and have impaired lymphatic drainage. This is distinct from the primary infection site, which heals. Reactivation TB tends to progress. You end up having inflammation, necrosis, and the development of a cavity. If you would happen to have this local inflammatory response occurring near an artery, you can develop this thing called a Rasmussen aneurysm, which is basically a pseudoaneurysm or mycotic aneurysm in the setting of TB. Rasmussen. It's got a fancy name, so that immediately makes it high yield. So let's review. When do you see cavitation? So you remember that cavitation is going to occur in post-primary TB and reactivation TB. Now, what is this Gone lesion? That was that original infected site that calcified. What is a Ranke complex? That was the Gone lesion plus the lymph nodes. Bulky adenopathy. This is something I didn't touch on. Really bulky adenopathy. Who do you see that in? That is something that you see in kids. Like 90% of the time, when kids get TB, they develop this really bulky adenopathy. It's much less common in kids. Now, remember, the thing that doesn't happen in kids is the pleural effusion. That's something that happens to adults. So, typical location for reactivation TB, remember I said that was the areas that have high oxygen tension and low lymphatic drainage. So, posterior segment of the upper lobe, superior segment of the lower lobe. Miliary spread, when does that happen? That is, remember, hematogenous dissemination. Remember the lymph node that got big and then busted? Hematogenous dissemination, usually in the setting of reactivation, but can occur in primary progressive as well. So it doesn't necessarily have to happen. Basically, anytime you have your immune system is not working. So the scenarios for that, primary progressive or reactivation. That lymph node just grows and grows and grows until it gets out of control, and then it pops. TB presents as reactivation pattern in HIV patients with a CD4 of what? So greater than 200, you can think about, so this is going to be in contradistinction to this question in red, which is primary progressive occurs when. So in primary progressive, you couldn't stop it to start with. So that has a really low CD4 count, so that's less than 200. In reactivation, you at least stopped it to start with, but then it came back. So that's more than 200. So that's more of an HIV person as opposed to a full-on AIDS person. And when does TB present as lobar consolidation in HIV patients? Does that happen? That's actually uncommon. That's an uncommon presentation. Okay, so we finished talking about TB. Now let's talk about this. This is an Ant Mini. This is your crazy paving. Now, there is a differential for this: edema, hemorrhage, BAC, AIP. But for the purpose of multiple choice test, this is only pulmonary alveolar proteinosis. That's it. No differential for multiple choice. Remember, multiple choice tends to deal in absolutes, just like a Sith. So what is crazy paving? Crazy paving, by definition, is this ground glass opacity that has intralobular septal thickening. The treatment, if someone would ask, remember, people who write questions want radiologists to be real doctors, so they know treatments. It's an alveolar lavage. That's how they try to treat this. Okay, next case. This is a gamesmanship case. So we've got a lung finding, but then you're showing me a bone window. So anytime there's a pulmonary finding that's not being shown in a lung window, you need to put on your gamesmanship hat. And we've got two different cases. I'm going to show two different situations where this is, you can problem solve. So if it's bone window, then it's pretty much going to be one thing. It's going to be this: alveolar microlithiasis. So this is basically deposition of calcium phosphate. It tends to affect the lower lobes, and the trick is that they're going to show it on a bone window. Pulmonary finding on a bone window. So there is an association, which is easy to remember, Testicular microlithiasis. Remember, this is the controversial entity that may or may not be associated with testicular seminoma. It's another, it looks like there's dense things being deposited, so it makes sense that those entities would go together. All right, here's another Ant Mini. Zoom up on that. This is your finger in a glove. This is your ABPA. The thing to remember about this is asthma. Asthma. It only occurs in asthma. So, aspergillosis can occur in a variety of different settings, and it depends on the host on what the pathology ends up looking like. So, in an immunocompromised person, this is when you're going to see your halo sign, which we talked about in the first module, which is your infection here, spreading out and creating little microhemorrhages and stuff as it invades into the microvasculature. Your air crescent sign, which is actually a sign of healing. As this thing retracts, you get this halo right here, or crescent occurs right here as this thing retracts down. Now, contrast this to your immunocompetent person who is they've got a cavity that they have occurred from prior fibrobullous disease, and then that cavity becomes inhabited by fungus. So this is what's called a mycetoma. It's fungus that's colonized the pre-existing cavity. It's not invading into anything, and this is an immunocompetent person. And then the third scenario is your hyperimmune patient. And this is the person with asthma, and this is your finger in a glove. So let's compare and contrast these two entities. On the red, we're seeing a mosaic attenuation pattern, and on the top, and on the bottom red, it's a bunch of what looks like centrolobular ground glass nodules. Now, why did I call it centrolobular? Because if I squint, it looks like it's sparing the pleura. Remember, that was how you could tell. Random nodules and perilymphatic nodules will involve the pleural surface. And then on the orange, we're seeing, again, more mosaic attenuation and what looks like maybe UIP, bronchiectasis, and the suggestion of some honeycombing. So what we've got here is two different kinds of hypersensitivity pneumonitis. We've got hypersensitivity pneumonitis that is occurring in the subacute setting, and then we've got hypersensitivity pneumonitis that's occurring in the chronic setting. So when people call it acute hypersensitivity pneumonitis, what they're actually talking about is subacute. The truly acute phase is basically never seen. If you would happen to see it, it would just look like pneumonia, just an airspace consolidation. Subacute is the ground glass centrolobular nodules and this mosaic perfusion. Now, notice I didn't call it air trapping. What it is actually air trapping, but you would have to have an expiratory phase to prove that. Now, the chronic hypersensitivity pneumonitis is sometimes called the head cheese sign just because it looks like a whole bunch of different shit mixed up together. And the way to remember it is basically you still have air trapping, which is going to look like a mosaic attenuation pattern. And then you've got fibrosis and honeycombing. So after a long period of time of being inflamed, the lung eventually gets fibrosed. So UIP plus air trapping is chronic hypersensitivity pneumonitis. And subacute is the centrolobular ground glass nodules. All right, so I touched on this before. We've got what looks like mosaic attenuation, which a lot of people will call air trapping because they don't know what they're talking about. on this inspiration film. You can't actually call it, though, because basically mosaic attenuation is, these areas that look like they're different attenuation. But that could be because of differences in perfusion, which is like small vessel disease, or it can be secondary to actual air trapping. And there's no way to know unless you do indexpiratory imaging, or you're having the person, because normally a CT scan is obtained. Take in a deep breath and hold it. Don't breathe. It's the opposite when you want expiration. So this is typically part of an ILD protocol where you're having the patient breathe out, and that's why you do expiration during an ILD protocol, is distinguished between small vessel disease and small airway disease. Okay, so we've got this versus that. So in the orange, we've got what looks like bronchiectasis, bronchial wall thickening and stuff, and it's favoring the right middle lobe and the lingula, so that's pretty classic distribution. Probably know that as this Lady Windermere or MAC. And then on the yellow, it looks like maybe that's TB. We've got a cavity in the upper lobe, apex, and a bunch of tree and bud and opacities. Sort of looks like an infectious process going on here. Some more less going on here, but all this shit here plus that. So these are both MAC cases, and it's two different presentations. One is the non-classic, or the Lady Windermere, versus the classic, or the cavitary type. So what are the demographics? The Lady Windermere is the old lady. It's just not ladylike to cough. So these are old people who don't cough. It's sort of an indolent infection, hangs out forever. The classic, or the cavitary type, is an old person who smokes, a COPD or old white guy who smokes. So remember, not all Mycobacterium is TB. Okay. Distributions are different. Right middle lobe and lingula, that's very classic. First-year residents typically know that or have seen that before. But a lot of people have not heard of this classic or cavitary type. Upper lobe, cavity, adjacent nodules. Can you say for sure that's not TB? No, but this is a pretty good look for cavitary type of MAC, or Mycobacterium avium intracellae complex. Okay, so this is a trick. They used to show this to first-year residents right before they would take call to try to scare them. They would go on describing the various degen in the neck, and then not notice the tiger in the tall grass. That guy. Interesting. So that's your superior sulcus tumor. Notice I didn't call it a Pancoast tumor, because by the book, Pancoast tumors have to have Pancoast syndrome. Pancoast syndrome is basically shoulder pain, radiculopathy, and a certain distribution, and Horner syndrome. What kind of a cancer is a superior sulcus typically? It's typically a squamous cell cancer. And the way that I remember that is S for S, SS is S. Superior sulcus tumor is squamous cell. This used to be the big oral boards question. When is this thing not resectable? Basically, if it involves the brachial plexus, if you've got nerve involvement that's causing diaphragm paralysis, or if it's eating the vertebral body up to greater than 50%, or if you've got distal disease. And the reason that matters is because it helps you understand this next step question. So if they want you to stage it MR is actually superior to CT because that can help you decide whether or not there's been brachial plexus involvement, which, as mentioned previously, makes it unresectable. So this is a treatment, this versus that. Now, these are two different entities. They are not the same. The one in the orange is an intrapulmonary abscess. We can see that there's some pneumonia here. And then we've got this necrotic stuff that looks like it's got fluid and gas in it. And probably once a week, family medicine would call down asking for drainage of this. Or it still does, and still does. Contrast that to the case in yellow, which is the split pleural sign of an empyema, where you've got enhancing pleura here and enhancing pleura here, with fluid outside of that in the pleural space. So these are treated differently. Empyemas can be drained with a tube. Pulmonary abscesses do not get drained with a tube. Don't let them talk you into putting a tube in that, because that, if you do put a tube into it, you're going to end up with a bronchopleural fistula, which is a massive pain in the ass to get rid of. All right, so this is just like our bone window case, where we're showing a pulmonary pathology on a soft tissue window. This one. And the reason this is done, so if it's shown on bone, alveolar microlithiasis. If it's shown on soft tissue window, you need to be thinking, is this like a hilar finding? Is it a lymph node finding? Is this sarcoid where they're trying to show me pulmonary and lymph node findings? Or is it this entity where the density here is similar to the density here? So it's fat. There's fat in this pneumonia. This is a lipoid pneumonia. So they basically come in different flavors. Now, if you did family medicine, you would find that you'd spend a not an insignificant amount of time addressing the psychopathology of bowel obsession that occurs in old people, where all they want to talk about is how often they poop, and they're all addicted to various laxatives and can't stop taking them. And because they're old, they tend to aspirate them. So old people who take laxatives aspirate mineral oil, and they create these lipoid pneumonias. Now, you can also see them in idiots who do fire-eating tricks or kids that accidentally poison themselves. And then there's also a more common type that's not even thought about, which is a lipoid pneumonia occurring in the setting of a cancer or some other post-obstructive process where you end up having lipid-laden macrophages building up in this post-obstructive situation. So let's do an airway case here. Compare this orange to the red. The orange is showing a massive, massive, massive trachea. It's a big one, bigger than mine. Versus the red case, which you can't get a glimpse at the very bottom here, right where it's bifurcating, and that looks pretty normal. But then you've got all this bad bronchiectasis, really severe bronchiectasis. So this is Munaer-Kuhn, which is this massively dilated trachea. That's the only thing that looks like that. It's an Ant Mini. And this is Williams-Campbell syndrome, which is an absolute total zebra. It's a congenital cystic bronchiectasis because you're missing the cartilage in these more distal bronchi. And that could be a couple of different things, but in the absence of a history of a lot of infections, that's what you're looking at. So let's talk a little bit more about airways. This is an airway case that's abnormal. This is TBO. Now, how did I know that? Let's go through a game plan here. When you're dealing with trachea cases, you need to ask yourself, one, does it involve the posterior membrane? 2, is it focal or diffuse? And 3, is there a bunch of calcified nodules? So if you remember from anatomy, the trachea is like a U, and it has a membrane that's not calcified along the back. And if you do inspiration and expiration exams, you'll notice that during expiration that the volume of the trachea actually decreases by about 30% on expiration. So breathing in, there's a big influx of air, so it pushes it out. Breathing out, it's the opposite. Pressure changes, pushing that membrane in. Expiration. So this is useful because diseases that involve the cartilage tend to spare this posterior membrane versus more diffuse processes that involve the whole thing circumferentially. So things that spare the posterior membrane, that's your TBO and your relapsing polychondritis. And I will point out, for the purpose of remembering that both of these entities have chondro in there, making you think that it's the cartilage process. Therefore, it would be sparing the posterior membrane. As opposed to these more diffuse inflammatory things like Wegener's or amyloid, which you can imagine doesn't give a shit if there's cartilage there or not. It's just inflaming the whole thing all the way around. So here's a scenario where we have both entities are sparing the posterior membrane. One of them has calcified nodules and one doesn't. So the one that doesn't is relapsing polychondritis. And the one that does is TBO. And the way I remember that is TBO just sounds bulkier to me, and therefore it's got these bulky, sort of pointy, scary-looking nodules. Relapsing polychondritis, there's association that you need to know. Think about this like cartilage inflammation. So it's got itis at the end of the word, right? So that's like inflammation. So if it's an inflammation of the cartilage in the trachea, it may affect cartilage other places, which it does, so you can get inflammation. Now, also, if you're not clearing secretions normally, you can get recurrent pneumonia, and that's actually what ends up killing a lot of these patients. So now let's talk about the entities that involve the posterior membrane, or can involve the posterior membrane. Wegener's and amyloid. So amyloid, which is a deposition disease, right? That's how I remember that it's depositing calcified hunks of stuff, versus Wegener's, which is just more of a diffuse process. So remember, Wegener's, C-ANCA, involves the trachea about 3% of the time, or 15% of the time. It's got 3 different things it involves: upper airways, lower airways, and kidneys. 1, 2, 3, A, B, C. Third letter of the alphabet is C. C for 3. So C-ANCA, 3 things: upper airway, lower airway, kidneys. W sorta has 3 points at the top: 1, 2, 3. 3 for 3 things, 3 for C-ANCA. And then the other one is the other one. So let's compare and contrast these two things. We've got a saber sheath appearance. We can see that there's emphysema in the lungs here on the red. Versus, this is coronal here, clavicles, coronal. This is an axial. That sort of looks saber sheath there, but then we see that it's a more focused look. And this is a classic appearance for post-intubation stenosis, which is supposed to look like an hourglass. And you imagine that sort of looks like an hourglass there. Post-intubation stenosis tends to be focal. Saber sheath is a long segment, and this is something that occurs in COPDers. So this is another airway question, and this one is a normal variant of anatomy. Notice there's a bronchus that is taking straight off of the trachea, filling this upper, or feeding the right upper lobe. This is a common variant called a tracheal bronchus. Some people call it a pig bronchus. I like to call it a pig bronchus. I like to put that in a report. The patient has a pig bronchus. Bury it in the findings. Okay, so this is the end of part 2 of this lecture, and the third part will be a vascular lecture.